It is my great pleasure to introduce our next speaker, Dr. Adam Lockitz. Dr. Lockitz is interested in integrative medicine approaches to pain management. He works with patients in substance use recovery with the goal of returning patients to work and normal daily activities. Additionally, he enjoys helping veterans and will work with all patients who seek to find the best way to manage chronic musculoskeletal, spine, and other painful problems. By the nature of the training in physiatry residency, Dr. Lockitz is comfortable treating patients who have had catastrophic or near catastrophic injuries or illnesses. Great pleasure to welcome Dr. Adam Lockitz.
I did pull a switcheroo on the title. I had said it was going to be about opioids. I further expanded it to all analgesics, and you'll see why in just a second. Well, if not, we'll just continue. So I'm Dr. Adam Lockitz. I am the physician and owner of TimeWise Medical. We have been serving patients in Minnesota, Wisconsin, North Dakota, now South Dakota, and soon Texas over the last 14 years. I started and took over TimeWise Medical from a retiring physician in 2010 and bought the name and the practice from him. I am board certified in physical medicine, rehabilitation, and pain medicine through anesthesia training. So my background is in delivering medications and needles and procedures and all of that, but also in managing high doses of opioids. And I hope after we visit today that you'll understand a little bit about the extent of analgesic overuse, distinguish how medical cannabis can often reduce and replace some of the common analgesics that we consume, maintain that medical cannabis can treat the symptoms of analgesic withdrawal and also other withdrawals of other substances very safely in an outpatient setting, and learn to use cannabis to decrease the continued overuse of analgesics. As you all know, opiate overdoses continue to go up, and our state is no different than any other state. This data is going back from 1980 through 2016, and I emphasize it primarily because it points out how this has peaked and how it's gone beyond what we even consider normal tragedies and other tragedies that have happened in the U.S. If you're not familiar with this particular documentary, I'd encourage reviewing it. It's called The OxyContin Express. It was something put together by Joe Rogan. They went undercover into Broward County and showed the extent of opioid overuse and the mismanagement of opioids in our community. Has anyone seen this, just out of curiosity? No, it's worth your time. Okay, so I grew up and started practicing in the 90s, just as the WHO analgesic ladder was taking effect and as doctors and hospital systems were starting to take note of treating pain in a different way. And so this was a strategy initially proposed to treat pain. And so as it was put forward in 1985, I thought it was appropriate to also sprinkle in some 1985 hairdos, because of course, nothing is more distinct than a 1985 hairdo. So here we see SPJ rocking it. So the WHO analgesic ladder was initially designed to treat cancer pain and palliative care, and this was a response aimed at improving strategies for cancer pain. I don't know if you recall, but back in the 90s, doctors were being sued for the mis- and under-treatment of pain. Does anybody remember that? That's a long time ago now, but that's how this all got started. And so why do I bring up this old WHO chestnut, this analgesic ladder? Because things have gotten updated in it, and if WHO continues to be a dominant health organization in the world, I think it's very important to at least know how to interact with WHO. The creation of this was also to create shared strategies, which I think also was obvious was a profit motive involved. There was a development of a global network, which one can argue that's also being put forward today as WHO continues to dominate the health organization and, in my opinion, is participating in fraud. So let's take a step back to the good old days. We were using analgesics in the form of NSAIDs and acetaminophen, and then we were using, with or without, what they called adjuvants. Now, to start off by using these drugs and then continue to use them indefinitely, you might as well just take a shotgun and put it up to your kidney or stomach, right? Long term, that's what you're doing. You might as well just make it quick. Secondly, we started off with weak opiates, hydrocodone, tramadol. A lot of patients don't even know that tramadol is an opiate to this day. I've had patients come to me because, of course, as soon as you go to see Lockett's, you get cut off from your opiates from the pain doctor. And so I've had opiate withdrawal with tramadol, patients coming in and 300 milligrams a day of tramadol. They had no idea that they were even on an opiate. So this was a quick, fast one that they did, and to feed the revolving door that is addiction medicine. And I actually have a true story. I have a friend who went to rehab with Judd Nelson twice. So third step was persistent and even more persistent pain. We got out the bigger opiates. We got into the fentanyl, with or without, again, these adjuvants. Does anybody know what an adjuvant is? Roughly. Okay. So now, if we fast forward with this lovely chestnut of wisdom that was passed forward by the World Health Organization, we can now see how that policy has played out in and around at least our country and throughout the world. And we now have a massive opioid-related overdose death. That number that I showed in 2016 has almost doubled. So, what is a WHO ladder adjuvant analgesic, and why do we care? Adjuvants, also called co-analgesics, were started and put forward as part of this practice in 1985, and included drugs such as amitriptyline, nortriptyline, SSRIs, and all the other types of newer manifestations of anti-epileptics, which were rebranded and remarketed as pain drugs, i.e. gabapentin, pregabalin, and then, of course, now we entered into an era of topical compounding pharmacy craze, where we got into topical steroids and topical analgesics. And all of that kind of came to a head with those compounding pharmacies. And I think it's important to point out that Minnesota is, again, very unique in its cannabis program in that we now have, 14 or 16 separate compounding pharmacies. And that's the important distinction of our program compared to all others. We work with pharmacists. Okay, so interestingly, what has happened in 2021 is there was an article that said that now the World Health Organization has said that adjuvants can be used as first-line treatment. And interestingly, they have now named cannabis as an adjuvant. So for the first time, we can now, under their definition, use cannabis as first line. So cannabis as adjuvant, WHO medicine, and the WHO analgesic ladder. The existence of the endocannabinoid system is the bedrock for understanding about the endocannabinoid system and how it affects us, but that's really just the beginning of the story. THC delta 9, the main psychoactive component in cannabis, is associated with the many beneficial effects, but it's also associated with the intoxicating effects. The CBD level, the terpene profile, and the other phytocannabinoid concentration ratios are extremely important in modifying the psychoactive effects of THC delta 9. One can think of the THC delta 9 as the engine driving down, and the CBD as the track. Medical cannabis is now the first sole treatment for any appropriate pain condition as a first-line independent adjuvant. So how does it work? Well, we know that Eastern European researchers were working on this. They later moved to Israel. Dr. Mechoulam et al. Became the first researchers to discover this. This is a mistypo. It should say the 60s, not the 90s, obviously. The endocannabinoid system works with a variety of physiologic processes, but the main effect is homeostasis. Homeostasis, and we've now discovered multiple ligands, multiple receptors. We know that it's based off of lipophilic transmission, and so it is considered a plant sterol. And when I tell patients that, they're always impressed. They're saying, "What? I'm on a steroid. I'm using that to treat my symptoms." Well, we're going to switch you to a plant steroid. And they're always appreciative of that. How does it work? Well, we have ubiquitous receptors in all organs for CBD1 and CBD2. It's through allosteric modulation, but the main thing, and I think the thing to just meditate on, is its effects on I'm one slide ahead here. I'll just talk about the natural antagonism between THC and CBD very quickly. This is almost considered yin-yang or counterbalanced. CBD is thought of as the responsible older brother molecule for THC. It does not have any psychotic or psychotropic effects. It does decrease anxiety, and I believe it provides a foundation and a serum level that one needs to maintain in order to tolerate other phytocannabinoids and other levels of THC. Simply using THC alone is not effective. And the way to really encapsulate this and really think about this from a meditative standpoint is really to think about our autonomic nervous system. The endocannabinoid system, the ECS, has direct effects on our autonomic nervous system. If you think about the effects clinically that we can see and how cannabis can benefit, if you literally just go through each of one of these individually and take a three-dimensional view of the sympathetic and parasympathetic nervous systems, you will see it has a profound effect on our homeostasis. This is the bedrock of homeostasis. Well, if that's true, doctor, then can cannabis be used to treat autonomic dysfunction? When I went to residency and fellowship at Mayo, one of the first rotations I went through was on the oncology section, and I took care of 15 patients with pheochromocytoma, which is a rare autonomic disorder of the adrenal glands, which causes autonomic dysfunction. And it turns out that, yes, you can use cannabis to treat autonomic dysfunction, or autonomic neuropathies, as they're also called, including the diverse array of symptoms. And this is because, again, the ECS affects the autonomic nervous system, the ANS. So, what are our contraindications or relative contraindications? In 8 years of practice, I have not had one patient end up in the emergency room for any type of psychotic event. I have had patients who have taken too many of the lovely capsules or liquids, ended up with what they like to term cannabis emesis syndrome, which is nothing more than taking a bit too much cannabis to the point of where the tummy doesn't like it and you get a bit upset. And really, that's the only severe issue I have ever seen with cannabis in 8 years. It is relatively contraindicated with patients who are on high doses of medications, and I think that's the important thing, is there has to be a medical consult with each and every cannabis patient, because it is their laundry lists of medications which get them into trouble initially, not the cannabis. The cannabis is always to blame, but is never actually the issue. So if you can think of the fact, and I'll get to a slide that points this out in a bit, there's a synergistic effect between cannabis and other medications, not at the brainstem receptor level where we see benzos and opiates responding, but in other areas. Here's one example. Cannabinoids affect opioids in a synergistic way. How do we know that? Well, there have been preclinical studies to demonstrate that the effective dose of morphine is lowered by almost 4 times and codeine by almost 10 times when co-administered with cannabis. In my practice, this is universally true. I instruct every patient who comes in on an opioid that they're going to need to reduce it, and if they're on other analgesics, likely they're going to need to reduce it. Any medications that are done in and around sleep, they'll need to reduce, and usually that's to their best advantage initially, because starting to reduce those and going through any initial sort of withdrawal from that and having the cannabis, again, able to stabilize the autonomic nervous system provides for a good and even better experience and improved quality of life. And over time, I would completely agree with Bradford and Bradford's documentation and study that this can reduce prescription medications in all of these various categories. I've seen it and I have experienced it. Because of the effect on the cytochrome P1A receptors, again, this is one of the main reasons why you need to look for drug-drug interactions, primarily by reducing the number of milligrams and eventually the prescriptions eliminating them one by one themselves as you down titrate and detoxify patients using this medicine. Okay, so my interest in cannabis medicine initially was from the opioid crisis, and I am still very interested in the efforts in Washington to make this more accessible. The Americans for Safe Access has a report card that I would encourage, if you're not familiar with, to look at. They rate every single state that has cannabis or doesn't have cannabis medicine and how they're doing in a very strict criteria and fashion. And one of the ways that they do that is through the opioid response card. And I think that this is very relevant. We don't, in Minnesota, have opioid use disorder as a qualifying condition yet, but I still think that that's something that we should look at in the future. And by doing that, we will then see an even more profound impact of cannabis onto the opioid crisis. The response card here, they look at a number of criteria, including does the state allow for chronic pain, which we do? Does the state allow for cannabis to be issued instead of opioid prescriptions? That I don't really think we're there yet. Does the state allow for opioid use disorder? No. Is doctor education on opioids available through the State Department of Health? Yes. Is opioid cannabis education part of the curriculum? No. I don't think there's any medical school that's teaching cannabis at this time. But can other criteria like pain be used? Is there a veteran discount? Is there same-day access with the doctor's recommendation? That would really be something, and it would really save lives. I know there's administrative burden involved with that, but I continue to hope that we could do that in a more timely fashion in certain cases. And is there sufficient research and development for breaks from medical cannabis facilities? That's probably something still on the horizon. So one area in particular which I think we really need to try to find inroads is long-term care facilities, especially with our aging population. We're definitely seeing an increased interest in cannabis in long-term facilities, and the question always arises, can we make this happen? There's a number of ways to do that. You kind of have to be a little bit, responsible with the patient. If they have family that can help them, there's certainly going to be a more high likelihood that they'll be able to do that. If there's no family involved and you leave it up to the facility, it becomes more of a question mark. I think we touched on some of the common misconceptions about the program. Doctors don't prescribe cannabis, they recommend for cannabis. Once a provider has a patient, they continue to be their patient, and they will be their patient as long as they're certifying them. And patients present typically as 20-something gamers. I think we're kind of getting past the stigma, but I'm really interested to hear other people's experience, personally and otherwise, with the stigma. Many patients can't tolerate medical cannabis due to the side effects. I wish that this program could have existed in other states before coming here, because there are many naysayers about medical cannabis still throughout the country, and I think a lot of that has to do with the medical oversight and administration that was put in as those programs were put into place. And I guess I just can't say enough good things about our program in Minnesota, because even though it was expensive, it would definitely showcase the fact that cannabis is medicine, and there's absolutely no going back on that. So I think it's here to stay. I already talked about its effects on other medications, particularly opiates, but again, in my experience, I've helped thousands of patients come off of not just generic types of opiates, but more of the addiction type, so methadone, buprenorphine-based products. All of those can be milligram by milligram whittled away at until they're finally gone and the patient is free of living a life without opiates. We've talked about some of the patient-reported benefits. As I've been in the program and working with patients for the duration, I would say at times I've probably helped between 10 and 20% of the patients in the program at any given time, and I'd say that the benefits reported are probably the same as what have been reported. Initially, there can be dry mouth. Obviously, adjusting for other medicines reduces the drowsiness and somnolence and fatigue and the mental clouding, which seems to get better. And over time, we see decreases in pain, improvements in quality of life and function, and reduction in future complications for our patients. So, running the numbers one last time of opiates versus cannabis, we're kind of all preaching to the choir here, but in general, we see a non-toxic substance that should be more widely accessible. Finally, in closing, I'd like to just take an effort to rewrite the WHO analgesic ladder. If we could say the good new days would consist of non-opioid analgesics such as plant-based sterols commonly found in hemp, such as cannabinol for sleep, combined with up to 5% THC or equal parts with CBD and consumed in non-inhalable, i.e. tincture routes of administration, such that no intoxicating effects are possible, and so as to avoid the common overuse of over-the-counter anti-inflammatory drugs or acetaminophen with or without adjuvants. For moderate pain, stronger ratios of THC to CBD, 1 to 3 up to 1 to 30, and dry flower vape such as Volcano or others, so as to avoid over-the-counter med usage and its known toxicity, and also weak opiates, with or without non-opioid analgesics, with or without adjuvants. To be known to be dependent-forming and potentially addictive, even with several doses in many cases. Third step, we'll get to severe and persistent pain. We get to more non-smokable concentrates, vapes, dabs, wax, shatter, batter, live rosin, so as to avoid potent opiates and, again, adjuvants with or without, which are known to be addictive in many cases related to overdose deaths. So this could obviously be done as a committee, but this was just my first step to rewrite for the 21st century the WHO analgesic ladder. Time for questions.